Hello and welcome everybody to the virtual Midwest Concussion Clinic's monthly lunch and learn for October. My name is Matt. I am the owner of the virtual Midwest Concussion Clinic. We do these little monthly lunch and learns every third Wednesday of the month at noon Eastern time to sit down, chat a little bit about concussions and try to bring awareness to an injury that most people don't realize exists outside of sports. So again, my name is Matt. You can follow along on all of our social media platforms at mwconcussion.com on Instagram, Twitter, X, TikTok here at Midwest Concussion Clinic on YouTube and Facebook, as well as LinkedIn. I'm happy to interact and grow my community and learn and spread the awareness of concussions. So without further ado, this month's monthly lunch and learn is titled "Beyond the Sidelines: Navigating the Return to Learn, Work, and Life After a Concussion." All of everything when it comes to getting back to concussion recovery or determining whether or not somebody is healthy to play, people will have heard of, the return to play protocols, return to play, from the NFL, from high school, from college. That return to play protocol everybody tends to be familiar with if they've been around sports long enough or they've watched sports. But what happens if, number one, I'm not an athlete? How do I get back to work? How do I get back to learning in the classroom? And most importantly, how do I take my life back after a concussion? So join me as we kind of jump into how we navigate concussion recovery and reintegration back into life after a concussion. The four things that we're going to cover during the webinar today is, number one, we're going to talk about concussion expectations and recovery guidelines. We're going to talk about, what is kind of a common recovery trajectory and timeline, what sometimes happens with certain people, and we'll cover, kind of what indicators we'll see to determine whether or not that's an issue. The second thing that we're going to cover is return to learn protocols, what they are, how to implement them, what steps to take if you're trying to return back to a classroom setting and you need those accommodations. The third thing that I want to cover is we're going to talk about how we return back to work after a concussion. A lot of onus, a lot of focus is put on that getting somebody back into their day-to-day life or back on the play. But what do we have for those adults that are struggling to get back to work? What does returning to work with the concussion actually look like? And with that, we're going to break it down into a couple different types of jobs, but mainly we're going to stick to two major components. We're going to stick to traditional office work, where I call a desk job, and then a manual job, something that requires manufacturing, physical labor, to kind of talk about what return to learn or return to work looks like on those ends. And finally, we're going to come back to how do we turn back to our normal lives? What happens with concussions in terms of people isolating and removing themselves from their day-to-day lives, and kind of things that we can do to integrate and return ourselves back to our normal lives following a concussion. So without further ado, why does this really matter? If we look at the big picture, why am I even talking about it? Why am I spending my time, putting together a webinar, putting together a presentation to talk about getting back into life, work, and academics after a concussion? And the number one reason is because people don't. People don't sit down to take time to talk to you about what could happen and kind of what effects the concussion has overall outside of the athletic world, or somebody who's not an athlete or an adult. What is there available, and how does this work with, going through the kind of the recovery trajectories, and what's possible during, concussion recovery for those people. Sorry, a little technical difficulty on my end that I'm trying to navigate. Okay. Sorry about that. So overall, why does this matter in the big picture? One of the primary reasons that I sit down and talk about it is the idea that when you miss work or school, it leads to increased stress. Okay. So trying to figure out how to navigate that return to work or return to learn, trying to figure out how you're going to manage all of the aspects of life that come with missing school or missing work can cause increase in stress. We talk all the time about the one thing we need to control during concussion recovery is stress. If stress goes up, symptoms go up. If symptoms go up, recovery takes longer. If recovery takes longer, stress goes up. So we have to look at how can we navigate and focus and reduce the stress that comes with missing schoolwork or missing time. The second reason why it matters for the most part is that sensory overload does cause delayed recovery. So if sensory, if our system goes up, if we're exposed to too many stimulus at the same time, if we're exposed to too many things all happening back to back, it causes sensory overload, which leads to more headaches, dizziness, nausea, physical symptoms, emotional symptoms, cognitive symptoms. Sensory overload, when it occurs, is debilitating. It keeps us from doing our day-to-day lives and day-to-day routines. It really messes with our ability to go through and navigate life after a concussion. So we talk about these type of things because we're trying to reduce the amount of sensory overload that happens during concussion recovery. The third one is isolation leads to a mental health decline. If we have somebody who's struggling with reintegration back into our daily work, daily school, academic schedules, or life in general, we tend to isolate more. If we isolate, that leads to a decline in our mental health. One of the biggest changes when it comes to concussion recovery that we've looked at is the idea that we no longer want you to just sit in a dark room and wait. We don't want you to sit there and kind of think about how bad you feel and go, all right, well, eventually you'll feel better. But until then, you're just going to sit here and not do anything, not be around people, not interact with friends, family, stay off electronics, all of that stuff. What happens when you do that is somebody tends to isolate. When somebody isolates, we struggle with that reintegration back into life. So the idea behind these protocols and why we're going to address them is that I want you to understand that my goal during concussion recovery and your goal during concussion recovery should be to try to get back into as much of your normal routine as you can without overloading your system. Okay. So it's that fine line between doing too much and not enough, because we're trying to make sure that you're not falling behind, not feeling left out, not feeling invisible during your concussion recovery. And that leads to mental health challenges. So the primary reason we want to do certain accommodations or certain ways to get you back to your normal routines is that if we can do them early, an early structured support system improves concussion recovery. What that means is the more structured, the more things that we can do to eliminate symptoms early on or control symptoms early on and reintegrate you back into your normal routines, concussion recovery tends to go better. Your recovery timelines go down, your recovery trajectory is a lot more smooth and predictable. But one of the biggest challenges that we face, especially as adults when we're talking about reintegration back into work and life, is that it's hard to get somebody to abide by that early on. Either one, they've been told different, like, hey, it's just a concussion. You'll be better in a couple of days. Things will go well. You should be fine by now. Or they don't even know they've had an injury to begin with. They were in a car accident and everybody talked about whiplash, but nobody really talked about the brain injury side of things. So they don't know to take those precautions and take those things to kind of control symptom spikes early. And, if we can sit down and do these type of webinars and discussions, we can get those people that are sitting at home, not doing anything, trying to listen to their provider and listen to what they're being told of, like, just sit in this dark room and wait. And we can talk about there are options and ways to get you back into life, to assume, to control your work environments and your academic environments, to get you back into those routines to help us from the recovery standpoint. In the big picture, when it comes to concussion recovery, I work with somebody an hour to 2 hours a week. I don't work with somebody for, 30, 40 hours a week like a job does. So if I have somebody who's completely off of work, well, that means that we've got to fill a void of 40 hours a week where you're interacting with people, you're working, you're moving, you're fatiguing yourself, your sleep-wake cycles are off because you're not doing anything. Your energy production goes down because we're not up and around, not doing things, overall in the big picture. So that early structured support improves concussion recovery because we can control the amount of sensory overload that occurs. So the next thing that I'm going to touch on is our recovery expectations. Science has told us and research tells us that most people will get better within 30 days. Realistically, that is not everybody. Okay. The older research used to tell us that 80% of people would get better sitting in a dark room within the first 30 days, that you didn't need any help. We used to tell you that concussions were bruised and they'd last for 2 or 3 days, and then all of a sudden you'd be better. That's not that's not realistic anymore. That's not what research has proven to be different. Concussions are a traumatic brain injury that directly affects your ability to think, process, go through your normal routine, produce energy. It's something that we need people to understand, that it's much more than just a bruise in the big picture. So if we're looking at recovery expectations, one of the keys that I want everybody to understand is that it's going to look different for everybody. Everybody's concussion recovery timelines are going to look a little bit different. Most of the time, we say concussion recovery goes smooth for that first 30 days. Usually you feel back to normal, but that is not everybody. My clinic is built for those people that are not back to normal after the first couple of weeks, that are struggling with trying to reintegrate back into their normal lives. That the focus of my clinic is getting adults to take their recovery back into their own hands and try to navigate through concussion recovery when their traditional healthcare world has kind of let them down. So when we talk about these type of things in recovery expectations, don't get me wrong. I understand that there are certain people that recover within those first 30 days. And I know there are people that take a longer time to recovery than just those 30 days. So there's a big difference between medical recovery and functional recovery. What I mean by medical recovery is physiologically, the brain does recover within the first 30 days. Physiologically speaking, the energy production over the first 30 days is supposedly supposed to go from minimal energy production back to its normal routine. The brain tends to settle itself back down metabolically in that first 30 days. That does not mean that you're not going to be symptomatic for longer than 30 days. That does not mean that we're not going to have an increase in some pre-existing conditions or we're going to develop new stuff after that concussion injury, after that 30-day window. It just tells me that medically, metabolically, generally the brain takes about 30 days to go through a full neurometabolic cascade transformation. Okay. The medical recovery is normal advanced imaging. Most of the time, concussions are not going to have any structural damage that occurs with them. I can argue at the microscopic level that there's going to be structural damage that occurs, but I can't take a picture of the brain and look at it and say, hey, look, you've had a concussion for the most part. If there's anything that shows up on advanced imaging, generally it's major structural damage that's occurred or bleeding inside the brain that's happened. And generally speaking, those are much more significant injuries than what we're dealing with when somebody who doesn't show up with anything on advanced imaging. So when we talk about medical recovery, the medical recovery side says neurometabolically, you should be better within about 30 days. You should have no advanced imaging. Baseline objective testing should be achieved back to kind of your objective testing should be back to kind of what we expect with a baseline level. And there are no quote unquote abnormalities. What does that mean? Okay, so when we look at medical recovery, there should be no abnormal head movements or eye movements, no subjective complaints of dizziness, headaches, nausea. But the medical world, when it comes to recovery, means that at rest, things are pretty good. Functional recovery is very, very different. Think about if you hurt your leg. I might sit in a chair and feel okay, but if I go up to run a marathon, now my leg hurts so bad I can't walk anymore. Would you be considered cleared if you had an ACL repair and after, 3 weeks I can ambulate unassisted without crutches and I'm walking through the, my rehab or my physical therapy office after 6 weeks without a knee immobilizer on and I'm fine? Just because you can do that doesn't mean that functionally you are ready to go back to playing sports. The same thing happens with concussions. When I'm asymptomatic at rest, that is step number 1 of concussion recovery, is that I can do things calmly in my controlled environments without getting dizzy, nauseous, headaches, or anything of that sort. Functional recovery is that I need to be able to do my normal routines day in and day out with any sort of symptoms or any sort of abnormalities that may limit what my normal routine is. That functional activities can be anything from I'm going back to playing football or basketball or baseball, I'm ice skating, I'm going out and taking my dog for a walk, or I'm back into my work environment and I'm able to twist and turn and sit down and stand up without getting dizzy or nauseous. I will tell you with return to work and return to learn protocols, the goal of these return to work and learn protocols is to essentially get you back into sort of a normal routine far before functional recovery occurs. That I, as a rehab professional, I will use return to work accommodations as a way of doing therapy. I want to know what you can do and can't do for how long that you can do it, what simulation environment troubles that you have to help me in the recovery world. So now we're navigating through our functional recovery. So there is a very big difference between medical recovery and functional recovery. We have to ensure that you're functionally recovered, and that's why most people will kind of balk at, well, my doctor told me I was better after a couple of weeks, or, I was told that, these symptoms can't be lasting this long, so it's got to be something else that's going on. Well, medically, you've recovered based on what their understanding is. That does not mean functionally you have recovered, though. Now I'm going to kind of go into the idea on what is normal. You hear me say it a lot. If I have any patients that I've ever worked with, they've heard this phrase more often than not. I have no idea what my patients are like normal. I don't. I have never met them normal, quote unquote normal. We are all not normal. Okay. What's normal for me is not normal for somebody else. So when we look at the rehab profession side, we're trying to get you into normal parameters, what people your age should be able to do, what people with your athletic abilities should be able to do, what people with your injury history or trajectory should be able to do. But the concept of what normal really is so subjective, it's ridiculous. I have no idea if you could do this before you got hurt or after you got hurt. I have no idea if you could stand on one leg and give me counting backwards from 100 by 7 if you were healthy. I don't know that. All I can tell you is that you should be able to do it asymptomatic. You should be able to do this overall without getting dizzy and debilitating symptoms that go up. We should be able to navigate through our day-to-day routines without getting debilitating fatigue and neurofatigue. So when we talk about the idea of somebody getting back to quote unquote normal, one of the biggest areas that we have to do is we have to balance that subjective report of feeling normal with the objective side of my testing looks normal. I work with a lot of different age groups, a lot of different patients in general. And, one of my biggest things that I will sit down and talk about, look, we have to balance what you're saying versus what I can prove. So if I have somebody who's telling me that I'm seeing, hey, functionally, a lot of these tests look back to normal, but you don't feel like you're normal, that you're still getting symptomatic when you didn't before, I have to change testing parameters. Whether we add different distractions, different environments, different times, we have to do things to essentially stimulate and simulate your normal work environments or your normal life routines. If I can't simulate those normal routines, I have to figure out a group of objective tests to test whether or not that your subjective reports of normal are physiological limitations, or if I've had somebody who's been hurt for so long, they don't remember what normal feels like, then we have to marry that relationship between physiological, psychological, and subjective. And that's where the challenge with brain injuries comes into play. Every single person that you meet during your concussion recovery that's trying to help you has no idea who you are normal. No clue. Even if I knew, even if I'm working with my wife or my daughter, I've known them my whole life, I don't know how they feel. I don't know what their normal feelings are. I can't sit here and say, hey, look, when you turned your head 13 degrees to the left before you got hurt, you could do it without getting dizzy. Today, I don't know if you can do that without getting dizzy. I have to assume that's the injury. So we have to go through and we have to mirror that back to normal. So when we start looking at the idea behind concussion recovery trajectories and timelines, we have to take normal with a grain of salt. In the medical world, especially when it comes to work comp or people being off for short-term disabilities or Family Medical Leave Act, being out of school, one of the hardest things to do is objectively prove what somebody is subjectively telling you. When we look at people who have struggled through years of being told that it's in their head, they're faking it, they're somatizing, they're going through and doing different things, other providers telling you there's nothing else that we can do, they have to make sure that we're looking big picture at what psychologically is causing issues, what physiologically is causing issues, and then the relationship between them. Very rarely is something just a psychological problem. Very rarely is something just a physiological problem. We have to make sure that we're addressing both things during our recovery timelines. So circling back to what our recovery expectations are, 20 to 30% of those that are diagnosed with a concussion will end up being diagnosed with what's called persistent post-concussion symptoms. Post-concussion syndrome is another word that they're trying to get away from using. It's nothing that an individual has done wrong. It's nothing that has occurred that all of a sudden I developed post-concussion syndrome. It's just a fancy way of saying that symptoms have lingered for longer than 30 days in adults and longer than 2 weeks in kids. Okay. It's an insurance definition. It's something that we were, that was adapted and trying to essentially use to show people that acute concussions don't always recover as fast as everybody wants. So every now and again, we'll get people that come in. It's like, yeah, I've got post-concussion syndrome. It developed into post-concussion syndrome. It's just a medical definition that says symptoms have lingered for longer than 30 days to 6 weeks, depending on which research you look at. Okay. So up to 20 to 30% of those that are diagnosed with a concussion will struggle with persisting post-concussion symptoms. 50% of our patients are symptomatic after 6 months. Okay. That number's skewed just a little bit. In my world, if I can get somebody to come work with me before that 3-month mark, before the 30-day mark, like I've hit the lottery if I can get an acute concussion to come in that's been, injured for less than 2 weeks. It's made my life so much easier because we can get started early. Realistically, those people that are still symptomatic at the 6-month mark, they either one, haven't been told they had an injury and they've just been trying to navigate through the healthcare world, trying to figure out why my head hurts, why my neck is fine and whiplash is healed, but I still can't, sit up straight. I still can't move my head without getting dizzy. Or they've struggled with not receiving treatment. And they're being told over and over again, hey, go sit in the dark room, stay here for 2 weeks, sit here for 2 weeks, sit here for 2 weeks. I am also realistic when it comes to some of the research is skewed on brain injuries. Nobody volunteers their concussion recovery timelines and trajectories when things go well. Okay. It's just like nobody donates their brain to science when they don't think something's wrong. So when we look at the CTE argument, one of the big things is, all of these brains that we're studying are coming back with CTE. Well, yeah, people aren't donating their brain when they're healthy. They're doing better and they're getting more science and research around healthy individuals, but it's tough to get people to buy in when there's no reason to, right? It's just like one of my go-to phrases is nobody cares about concussions until something happens. Nobody wakes up and goes, you know what? I want to learn everything about concussions today, unless they're interested or they're in the medical field. Very rarely do I have a 14-year-old that's just like, you know what? Concussions sound cool. Let me go figure out what to do in case I get one. Nobody cares about the injury until something happened. Okay. So that number can be a little bit skewed in that 50%, but I will tell you a lot of the patients that I'm working with currently, they're still symptomatic after that 6-month mark because we weren't able to get started early. Okay. The final thing is I'm bringing it back up again, and it's going to be a common theme throughout the reintegration back into life. Isolating after a concussion leads to mental health decline. Increase in depression and anxiety, PTSD, isolation, reservation, not talking, not going out and interacting with people. All of that will cause a delay in concussion recovery. Most people, they're isolating because going out and being around people makes me not feel good. I get dizzy, I get nauseous, I can't handle the overstimulation. So even going out to the grocery store puts me in bed for 3 weeks. I go out to church and all of a sudden I can't remember people's names and that makes me feel embarrassed. I'm stuttering or I don't remember words and now all of a sudden I have to go home. And when I go home, I'm dizzy, I'm nauseous, I'm throwing up. I just don't feel good. So they stop going out. They stop being around people. And when you're stopped going out and getting that extra stimulus, it delays our concussion recovery. So again, recovery expectations. We need to make sure that we're trying to keep people into our fine line between doing too much and not enough. We're going to flip gears a little bit and talk about the academic side. Return to learn protocols are something that have slowly started to be integrated back into every level of academics. I will tell you, it will be very challenging to find a college or university that does not have a return to learn protocol in place for their athletes. Okay. The NCAA has made it mandatory for every institution to implement some form of a return to learn protocol. Now, what happens with non-athletes, that's a different story. And you're hopeful that the university has things in place to help navigate return to learn for a non-athletic population. But now we start looking at high schools, middle schools, elementary schools. What are we doing to help somebody return back to school without setting them up for failure and increasing symptoms? So that's where return to learn protocols come into play. The idea behind a good return to learn protocol is we want strict mental and physical rest for the first 48 hours. The first 48 hours after injury is where all of the chemical response happens, where a lot of the kind of early recovery starts in that first 24 to 48 hours. So when we look at strict rest, that isolation, sitting in a dark room, no TV, no phones, no electronics, sit, sleep, and rest inside that first 48 hours is wonderful. If we can control external stimulus during the 48 hours, your recovery timeline gets significantly better. The challenge that comes into play is some people don't know that they're injured in that first 48 hours. Some people haven't been diagnosed. They don't even know what a concussion is. They've never even heard it, or they went to the emergency room and they were told their scans are normal. There's no concussion. They'll be fine. So they don't abide by that rest for the first 48 hours. Strict mental and physical rest in the first 48 hours for a return to learn protocol means that I want all of the athletes that I work with to be off of school for those first 2 days. I want them to lay low. Don't do any homework. Don't do any schoolwork. Sit at home, listen to the radio, listen to a podcast, and try to sleep as much as possible. The second kind of component of a return to learn protocol is we're trying to balance keeping a student from falling too far behind and overloading their system with overstimulation. It's a fine line, and I will tell you that return to learn protocols are very fluid. Does everybody need a return to learn protocol? Not necessarily. Every patient that I work with, I will sit down if they're in the academic age, I will sit down and put academic accommodations in place. Say, hey, we want more time for homework, more time for tests, attendance is tolerated. We want to do different things with screen time. We want to avoid testing if possible. And I'm not so dim to say that there are people that will not listen. I'm going to go back to school because I feel okay. I go take a test today and I got an A on it. I'm fine with that. And that's fine. Not everybody needs academic accommodations, but academic accommodations are put in place for every single patient that I work with because it's better to need it, and it's better to not need it and have it than have it and not need it. I don't think that was right. It's better to have it and not need it than need it and not have it. There it is. That's the one. Okay. So when we start looking at it, it's that balancing act by trying to get somebody back into school, staying in their normal routines, using that as a way of helping us get exposure to stimulus, but knowing that we can pull the reins back and take them back out if things aren't going well. What happens if I'm not in a traditional high school or middle school setting? What happens if I'm a college student or I'm a virtual student? What do we do for those academic accommodations? The easy answer is the exact same thing. We want to make sure that we get extended time for homework, extended time for exams, postpone exams if we can, and attendance in lectures is tolerated. Because there may be days where you feel good and you want to go, and then there are other days where you don't feel good. Okay? And then the final reason why we want to implement return to learn protocols is that when we have athletes or students or your non-athletic regular person, if we have somebody who misses school, that affects mental health. Feeling like they're falling behind, looking at their grade books that are all online now and seeing 12 zeros for somebody who's a valedictorian candidate will make them anxious, will make them stressed, will make them nervous, will make them feel overwhelmed. And then when they try to get back into their normal work routines, their normal academic routine, they will struggle with the mental health side of seeing all these zeros or absences on their record, knowing that they were out because of something they couldn't control. So we need to make sure that we're putting these in place to help the mental health of all of our student athletes or our students in general navigate through concussion recovery without the idea that they feel like they're falling behind or that they're missing out. Some key components of a standard kind of return to learn protocol. I use a 5-zone return to learn protocol where zone 1 is completely out of school. Zone 2 is I'm in school for a short amount of time and I'm literally just sitting there. It's called a clear desk policy. I want to show up. I don't want my computers. I want to sit there and just kind of listen to lectures. And then we're pulling you out of school really relatively quickly in the day. Zone 3 in our protocols are a bus-to-bus attendance. I want them coming in right as the day starts. I don't want them to go into extracurricular activities. We may have them alternating days, going Monday, Wednesday, Fridays, Tuesday, Thursday, half days. We may do some attendance modifications that way. But our zone 3 is generally something that, zone 1, 2, and 3 are generally something I don't want to put our student athletes in outside of that first 48 hours. Zone 4 is where I like to start a lot of patients that I work with. Zone 4 is a modified attendance and a full attendance as tolerated. So it's something that I put on every single academic accommodations letter that I send out. I want extended time for homework. I want extended time for exams, and I want attendance as tolerated. Okay. Because if I've got somebody who does really well Monday, Tuesday, Wednesday, but struggles Thursday and Friday, I want them to have that freedom to be out of school on Thursday and Friday. And I will work with the student to try to keep them in as much of a normal school as we can. So a normal kind of accommodations letters, those extended time for homeworks and exams, we want to postpone all non-essential homework and exams if possible. Especially as we come down to the end of quarters, end of semesters, if there's anything that's considered non-essential, if there's a fluff work in there, I'm working with every school professional I can sit here and say, hey, do we really need to do this? Or can we toss this aside, do something different to kind of get a double score or make up for some of that missed work? Because if we can sit here and take things that aren't essential, we can get somebody to do more of their missing assignments, more of their missing work, to try to get them back into their normal routine faster without the stress of I have 40 missing assignments and I've got to catch up. The final kind of two areas here: limited screen time during class. If I have something that I can get printed off and put on paper, it's a whole lot easier for a student to look at a paper lesson or homework than it is for them to look at screen time during concussion recovery. I am one to sit here and tell you that their entire lives are on screens. So we're going to make modifications to the screen to allow them to stay on the screens for a longer period of time. We're going to change brightness, change filters. We're going to do different things to make the screens more tolerable because their entire lives are on screens. I work in the medical world. I live in the real world. If I sit down with somebody and say, hey man, we're going to keep you off your phone for more than 20 minutes at a time. As soon as I turn around, they're checking their text messages. They're laying down when they can't sleep at night, watching TikTok or watching Instagram, like trying to figure out, what are my friends doing? What are my buddies doing? Like it's realistic. They're going to be on screen. So we're going to talk about how we get them back onto screens faster. Some special things to consider if you're trying to get your own return to learn protocols set up, or you're trying to get one for your student or for yourself, is that we want to have modified participation in our gym classes, swimming, PE, weight and strength classes, as well as band, orchestra, and choir, because all of those are going to change intracranial pressures. And then those PE, weight and strength classes, we're running into the risk of re-injury, the risk of hitting our heads again. So we want to make sure that we're getting accommodations put in place for those activities. For my younger individuals, recess and recreational hours. One of my go-to phrases with patients is, I trust you. I don't trust the people around you not to hit you. So I don't trust your buddy not to walk up and smack you in the back of the head and be like, hey man, I haven't seen you in 3 days. How are you? Or somebody be throwing a ball to somebody else at recess and it hits you in the side of the head. So we want to make sure that we're putting those academic accommodations in place for recess and recreational hours as well. And then two different things that most people don't necessarily abide by, but it's a really good idea. It's having a modified environment for them to eat lunch, sitting down in the office in a quiet conference room, going to the library to eating your lunch, to avoid the overstimulation of all the chaos and the noise and the movement that happens in a lunchroom. And the same thing goes with passing periods. Getting out of class 5 minutes early, making it to your next class. That way you're not trying to navigate the hallways with 400 of your closest friends all yelling and screaming and trying to run around doing all that at the same time to try to control our overstimulation. So the final kind of wrap up with that return to learn protocol is, again, that the primary goal is safe reintegration back into a normal routine while trying to avoid overload. When we look at a return to learn protocol, the idea is we're not testing the athlete or the student's injury, that we're testing their knowledge and ability. Concussions are the only injury that you get to the brain that directly affects your brain's ability to think, process, and retain new information. So by sitting there and doing those different things with return to learn protocols, we can assume that we're now testing the student's knowledge and not necessarily what's happened with the injury itself. And then the key component to every successful reintegration into return to learn is that a constant set of communication is established between the patient, the parents, the school, and the medical staff. I go around to schools a lot teaching reintegration and return to learn protocols and updating the gap between academics and concussions, with the whole idea that we're trying to establish communication between the school, the parents, the patient, and the medical team to ensure that everybody is on the same page during concussion recovery. So we need to make sure that there's constant communication between expectations of what the student has, what teachers need to be doing, and what the accommodations the school needs to provide. And then finally, return to learn protocols are fluid. Just because I'm in, I need a bunch of academic accommodations today doesn't mean I'm going to need that same list of academic accommodations tomorrow. So making sure that we're communicating and giving those kind of updates on recovery to ensure that we're making it through our concussion recovery, that we're making sure everybody is involved in that decision making and in that return to learn process. So again, we're going to switch gears to return to work. Okay. When we start talking about return to work, I touched on it again at the beginning a little bit. We're going to break it down into two different job categories. I understand that there are more than two different job categories, but I'm going to break it down into traditional desk jobs, lower physical demand, higher screen time, more cognitive demand, a little bit of a change in environments because the environments are relatively controlled. And then we're going to go into a blue collar or a manual job. A manual job can be anything from construction work to manufacturing, blue collar work, electricians. I deal a lot with linesmen in manufacturing, military, those jobs that require a lot more physical demand to their work and generally unpredictable environments at times, whether it's heat related, cool related, physically working in different elements, those type of things. So I understand that there are different types of jobs out there and that academic or that return to work accommodations are different for everybody. But just know when we talk about return to work in this presentation, we're going to break it down into those two categories. Some special considerations to make when it comes to return to work protocols after a concussion is one of the things that you're going to see pop up a lot when I start talking about adults. Life doesn't stop. When you have a concussion with a younger person or a student athlete, and I can sit here and say, hey, we got to take a couple of days off of school. Oh man, you mean it? I got to sit at home for a couple of days? Cool. I'll watch Price is Right and let's make a deal and I'm going to move on. When we start looking at adults, life doesn't stop. We can't just stop being a mom or a dad. We can't stop being a spouse or a partner. We can't stop going to work. We can't stop paying bills. Life doesn't stop when it comes to a concussion for an adult. So we have to make sure that we are trying to balance those self-imposed stress and expectations of getting back to work faster. I will tell you, every single adult that I work with, one of the first things that we talk about is the expectation that we will get you back to work as soon as possible because I understand that life doesn't stop. Most people will have some form of self-imposed stress where they're not recovering as fast as they think they should, or they're not able to do things as well as they think they should be able to, or as long as they should be able to. Self-imposed stress and expectations on students is something that we have to address. It is very, very difficult when it comes to adults. The second special consideration, financial stress and obligations. Again, bills don't stop piling up. Okay. I have to make a living. I can't not work. If I don't go to work, I lose my job. If I lose my job, I can't pay the bills. If I can't pay the bills, I lose my house. If I lose my house, all of a sudden I'm going to lose my kids. If I lose my kids, I don't know what's going to happen. And then we start the spiral of that snowball rolling downhill. So when we talk about adults and that reintegration back into return to work protocols, we need to understand that we have to balance that I have to return back to work mantra and lifestyle with the understanding that if we can implement these return to work protocols, things will go better for you and we can keep you at work for a longer period of time. The third major special consideration that we have to look out for is sometimes we have to protect the patient from themselves. Returning to work too early, especially with some of those manufacturing type of jobs, can be dangerous for the patient, for their coworkers, for the employer, and for everyone around that situation. If I have somebody who's driving a forklift that's dizzy and disoriented, I am no longer safe in my work environment. Okay. Liability wise, the employer is no longer safe if they have somebody back on a piece of machinery or doing something when they're dizzy or disoriented. So there are times where we have to sit down and look at a patient and say, hey, look, we're going to take a couple weeks off here because if we do, we can get you back within those first couple days, within those first couple weeks. If we don't, we run the risk of you spending too much time out of work and then potentially losing your job. So we have to find that fine line between protecting a patient from themselves and trying to get them back into work as best they can. On the flip side of that, I do have patients that have been off for work for too long. There is research out there that tells us that if you're off work for longer than 6 weeks, you are significantly less likely to return back to that job. Okay. Whether it's you completely change careers or you're with a new employer. Okay. So we have to find a way to get you back into work and keep you in work with significant modifications to ensure that you are able to navigate your return safely. Again, big bold letters on the screen, and this is more for kind of hammering home my point. Life doesn't stop after a concussion. Just because you're injured does not mean that the world around you stops. For multiple reasons, it causes problems. Students feeling left out with their friend group, not being able to do academics or compete in athletics, going back to work, feeling like you're going to lose your job when you're out of work, not staying up to work with those coworkers and up on the gossip of the office or falling behind on deadlines. And then in reintegration back into life, the life around you doesn't stop. Okay. Relationships change, friendships change, that life not stopping is a common theme across all age groups, across all walks of life, and all return to normal kind of protocols. So what are some of the key components to a successful return to work protocol? Very similar to a return to learn protocol. Return to work, generally, I want my patients to take the first 2 days after an injury completely off. Using PTO time, using FMLA work, whatever we need to do to get you to take those 2 days off can set yourself up for a significant improvement in your overall recovery. The second thing is it needs to be slow, controlled reintegration back into a planned space over time. Okay. One of the biggest challenges that we run into with getting people back to work is, hey man, I've had a couple really good days back in a row. I'm going to go back to working my normal duties from a normal schedule. I go from not working at all to working 8-hour shift out in 120 degree, the 120 degree factory where I'm bending and twisting over and over and over all day. It goes back to medical recovery versus functional recovery. Just because you're healthy and good at rest does not mean that you're healthy enough to go back into your normal kind of work environment right away. We need to have a plan to baby step you back in slowly and controlled over time. One of the things that we talk about with all of our return to work protocols, I want to be able to kind of get you to wade into the water, not cannonball off the deep end. So we need to make sure that we're doing things to slowly get you back in your normal work routines, whether it's days off in between, changes to kind of the hours that you're working, or changes to the job duties that you have. Accommodations will change based on what your job description is. So one of the first things that I do if I'm working with work comp, every work comp patient that gets sent to me, they get their job duties and restrictions that are sent over with them. So I know what their job description is. If I don't have that job description and I'm working with an adult, one of the first things I'm going to ask is, what do you do for a living? And run me through what a normal day looks like for you so we can determine what accommodations are accurate. I never want to put no driving or operating heavy machinery for somebody who sits at a desk all day. Okay. That just makes it look like I don't know what I'm doing and I've sent a blanket statement out to everybody. So accommodations will change based on job description. And then we want to be aware of all the financial options that are available. What do I mean by that? If you've been working for certain jobs for a certain amount of time, every paycheck that you have, you accumulate extended illness benefits and or the Federal Medical Family Leave Act, so FMLA. So what happens is if I have somebody with a concussion and they're going to be off work for an extended amount of time, or we're trying to do certain accommodations that are set in place and it's non-work comp related, we want to make sure that we're getting with our HR department to fill out FMLA paperwork to essentially use that as a stopgap. Now, it's not your full salary. For most people here in Indiana, it's usually about 60% of your total salary, but it's a way of kind of controlling the bleed financially if I have somebody who's going to be off work for a while. If I don't have any FMLA available to me, that's when we start looking at extended illness benefits. If your employer, puts certain amount of days each paycheck into an extended illness bank, we can use that during concussion recovery. And worst case scenario, you don't have either of those. We can look into, there are certain types of credit unions, there are certain banks out there that will actually do short-term loans to help people who have got extended illness benefits. We see it a lot if somebody's going to be out long time for cancer, if somebody doesn't have certain accommodations, if somebody's going to be out with pregnancy or with a surgery that they need help with, we can get, certain gap insurances like AFLAC, different things to help kind of bridge the gap in those loss of wages. So we need to make sure that we're exploring every different option available to us financially. That way we can help reduce the burden of, I'm not working, I'm not getting paid. I will tell you, if I have a patient that sits down and says, Matt, there are no other options. I either work or I don't get paid. We are going to go back to work and we are going to talk about how we can get back to work safely based on what their job duties are. I am one of those that totally understands financial stress. Okay? I'm a small business owner. I get financial stress. Totally understand that. So when I sit down and I have a patient, they're like, hey, Matt, I have to go back to work. Cool. Now we're going to work on what we can do in our daily work environment to help reduce symptoms and kind of control our environments to keep you in that work-related situation as best as possible. So some of the or some of the return to work accommodations that we put in place for office jobs. Again, those desk jobs, sitting down, more time in controlled office type environments, bright lights, controlled noise, relatively climate controlled. These are what I'm talking about with office jobs, quote unquote. General accommodations that I get is we want to modify computer screen time. If I have somebody who all they do all day is look at screens, we'll put a max cap on what what screen time I recommend. Usually it's about half of their work shift. If they're working a full shift, it's 4 hours. If they're working a half shift, it's 2 hours as max computer work at a time. If I don't put any formal restrictions in place, I will talk to all of my patients about the 20-20-20 rule. When it comes to electronics, the 20-20-20 rule. If I'm looking at a screen for 20 minutes, I need to look at something 20 feet away from me for 20 seconds. It's something that we're all actually supposed to do if we're working on computer or phone screens all day. I modify it just a little bit that if I have a patient who's struggling with computer screens, I'll have them set a timer for 20 minutes. Once that timer goes off, I want them to physically get up and walk away from their work environment for 2 or 3 minutes. Get up, go to the bathroom, get a drink, go take a lap around the office, go talk to stand around the water cooler, whatever. Give yourself a chance to totally remove yourself from the screen environment. One of the biggest challenges when I have somebody trying to take a break is like, all right, I want you to take a break. Then they're over here on their phone. It's like, okay, checking my text messages, updating my social media, trying to figure out where my work email's at. That's not a break. Just because you stop looking at one screen and you start looking at another screen doesn't mean you're taking a break. Another accommodation that I kind of want to put in place is if I have somebody who's working on dual monitors, I want them down to one monitor pretty quickly. I want to try to keep everything on a centralized screen as best we can. That movement and rapid scanning between different monitors causes problems. So I want to make them come down to one screen if possible. I want to try to control as much of their work environment as they can. If they're in an office where we can control and dim the lights, I want the lights dimmed while they're there. If they're not, I don't want them sitting directly under the fluorescent lights. And I teach them techniques that they can use to help hide their eyes. Putting your head down, kind of covering your eyes while you're looking at your screen, wearing a hat or a scarf over top of your head are ways that we can kind of control the light environment. But we also need to be able to control auditory stimulus and limited distractions if possible. If I have somebody whose, job is data entry and they're putting data into a spreadsheet, I want them to not think about the phone. I want them to unplug the phone, take the phone off, don't answer any emails until you're at a stopping point of the work that you're doing. We need to limit those distractions. If I have somebody who's allowed to wear headphones, I will tell them to play low-level music or noise frequencies depending on their tolerance levels to help control the auditory stimulus that they're going through. Generally with attendance, early on, we're trying to get them back into half days. Whether it's 5 days a week, half days, we want Monday, Wednesday, Friday, half days, or Tuesday, Thursday, half days. But early on, we're trying to get them a day where they have rest in between. So if I can get them to work Monday, Wednesday, Friday, half a day, Tuesday, Thursday allows them to recover. We can monitor how they feel after work on Monday, Wednesday, Friday. We can make adjustments with the goal of going a couple weeks at half days and then getting you back into full days. Some employers will not allow a half day schedule, and that's fine. I totally understand that. Teachers are one of them. It's a whole lot harder to find a sub for just half a day than it is to find a sub for your full day. So if I have somebody in that situation, I will try to push for a Monday, Wednesday, Friday schedule. I want a Tuesday, Thursday recovery day. And then as we progress, we're making a little bit, baby stepped into a normal return to work protocol. So what I mean by that is going 1 to 2 weeks at a time where we're going half days. A common one that we do is half days, Monday, Wednesday, Friday. We're doing treatment Tuesday, Thursday. Then after 2 weeks, we're going to go full days, Monday, Wednesday, Friday, doing treatment Tuesday, Thursday. And then another one we can do is we're doing full days, Monday, Wednesday, Friday, with half days, Tuesday, Thursday, doing treatment in the afternoon, and then trying to get you back into that full work schedule. The key is that we need to monitor our symptoms while we're at work and what changes once we get home. A lot of people that'll change when they get home is generally they'll be tired and they'll want to go to bed. And that's perfect. That's what we're after. Okay. But if they get significantly more symptomatic, their headache spikes, they get dizzy, they get nauseous, I need to know those things and we need to make adjustments overall. And then finally, a successful return to work plan. We have the assistance of extended medical leave, FMLA, extended illness benefits that we can use to fill the gaps in days that we're not there. If I have somebody who works 4 days in a row and all of a sudden they can barely get out of bed, we use FMLA with intermittent leave to get them that day off of work still paid with some form of financial compensation to it. shifting directions into a manual job, somebody who's manual labor, physical labor, manufacturing, construction work, the trades, somebody who has a more physically demanding job, more of the common accommodations that we do. No operating heavy machinery, no commercial driving. We want to avoid working near loud noises and bright lights if possible. That's really challenging in a factory setting. If I have somebody who's in a manufacturing or a factory setting, we want them to be able to wear noise canceling headphones to kind of control that external environment. The big ones, we want to make sure that they are not up on any ladders or unprotected heights. We don't know above ground work. The easiest way to describe it is I want both feet on the ground at all times, trying to make sure that we're not running the risk of you getting dizzy and nauseous 100 feet up in the air and then trying to figure out how you're going to climb down. And then we want to limit the amount of bending, twisting, and standing based on their job description. Again, those are some of the common ones, and we try to do the exact same thing that we would do with an office environment in terms of our attendance, that we want to make sure that we're doing different things. Finally, when it comes to manual labor, one of the keys for success is even if they're not able to do their traditional job, if we can find something for them to do in their work environment, it is more beneficial for them than them being off of work. Let's say I work in an automotive shop and I may not be able to work on cars right now, but I can clean the shop. I can do front desk work. I can be in the work environment for a short amount of time doing my job and then finding another job inside the office that I can do to help kind of fill the time. Being in the environment helps stimulate the brain. And when we're in our normal environment, it helps us regulate sleep-wake cycles. It helps us go through our normal kind of energy production, and it helps keep us into that daily routine that the brain absolutely loves and is looking for as it goes through and navigates its return to work protocol. Finally, and I'm going to say it again, life does not stop after a concussion. Life continues to go. There's stress, there's financial burden, there's the fear of losing a job. Life doesn't stop after your concussion. We need to make sure that we're doing everything we can to slowly reintegrate you back into your work and back into life in general. So what do I mean by that? Okay. We need to make sure that we are constantly communicating when it comes to work accommodations. Don't just assume that your employer understands that you're injury or that they remember that you have work accommodations. I will tell you in my experience, most of your employers, if they're not abiding by work restrictions, have forgotten that you have work restrictions. They have a lot of different employees that they have to work with. HR has a lot of different paperwork flowing in and out that most of the time, if somebody's not abiding by work accommodations, it's a miscommunication. There is very little malintent or malicious intent to it. Not always, but sometimes. Okay. So when we're looking at trying to reintegrate back into work and trying to go back to your return to work protocols, don't just assume that your employer or the people around you understand what you're going through. Use it as a chance to educate, communicate with them how you're feeling and what you're doing. They see you walking around the shop laughing and chucking it up with a bunch of people. But what they don't see is when you get home that you can't see straight, that you go lay in bed and you're asleep from 6 p.m. till 8 a.m. the next day when it's time to do it again. They don't see that stuff. So make sure that you're constantly reiterating with your employer how you're feeling and what accommodations that you're needing. And then finally is if I can get people to understand that if they take a break every 20 to 30 minutes, they will be in their work environment for a longer period of time. Even if I have somebody who's doing well at work, I want them to set a timer on their phone for an hour. When the timer goes off, write a note about what you're doing, get up and move around. Go do something else, get away from the computer, get away from the screen, go get a drink, go out and have a smoke break, whatever you need to do to physically remove yourself from your environment. Give yourself a chance to relax. Even if that's just 2 to 3 minutes of you dimming the lights, sitting back, closing your eyes and putting your head down. It gives you that ability to move away from that work environment, that work stimulus. And finally, the last part, return to life, kind of reintegrating yourself back into your normal routines. Again, life doesn't stop after concussion in this world either. That the people around you are going to continue to move on. There's still going to be, your kids' dance recitals. There's still going to be sporting events. There's still going to be hangouts that you're missing. There's still going to be the school dances or parties that you're going to, either one, try to go to and not do well, or two, completely missed. And that affects the mental health of the individual as well as everybody around them that has to watch My friends struggle with not coming to the homecoming dance, or that that I missed my work party, my work holiday party that I look forward to every year because I can't handle the noise of the bright lights. So life doesn't stop after a concussion. So when we don't stop, when life doesn't stop or we can't handle that, it leads to isolation. Isolation leads to depression and anxiety and withdrawing from people. That leads to lost relationships, which leads to more increase in depression, anxiety, and isolation, which leads to longer return or recovery timelines. So when we go through the effects of isolation, we want to try to limit our exposure to certain stimulus, but not completely avoid it. Okay. One of the things that I like to do with patients who are struggling with isolation is one of their homework assignments is I want you to go to Walmart. I want you to just get a cart and I want you to walk around for 5 to 10 minutes. Don't shop. Don't need anything. Don't go to pick up anything. I want you to go into the environment, walk around for a little bit, and then go home. I want you to try to go to church. I want you to have a phone conversation with a friend. I will talk about assigning those type of things to help with that isolation. One of the biggest challenges with concussions, they are an invisible injury and they make people feel invisible because the people around them may or may not understand what they're going through. So that limited exposure, graded reintegration back into life is a way that we can avoid isolation. We can communicate with those around us on what we need, and it helps us avoid canceling plans that could potentially make us lose relationships. That final thing with reintegration back into life is I want you to start slow. I don't want you to try to cannonball into the deep end. Very similar to work reintegration, very similar to return to learn protocols. We are not cannonballing off the deep end. We are slowly wading into the waters. I want you to try one thing and see how it goes. So if you're somebody who likes to go to church, hey, Sunday we're going to go to church. One of the biggest changes in church lately is everything tends to be a production. There's lights, there's noise, there's loud. I can tell you from a lot of experiences that I've got working with different denominations and different churches, they usually have a lower sensory integration hour. Usually it's either the very first hour or the last hour of service that they will actually have a low tech kind of service for people that struggle with overstimulation. I'll recommend, hey, go into that and see how we do. And if we can handle that well, now let's try to go out to dinner on Tuesday. If we can handle that well, let's try to go to the basketball game on Thursday. Slowly reintegrating, slowly adding things in without cannonballing off the deep end is key. The second key to reintegration back into your life is you need to communicate what you need. Really challenging at times when we don't know how to express what we need. But we need to make sure that we have established communication with your concussion support team, as well as open communication both ways. We need to be able to tell our support system what we need, and we need to be able as a support system to tell those that are dealing with their recovery and kind of communicate on what they need to ensure that we're helping as best we can. Just like anything else, life works better and more smoothly when we can openly communicate back and forth. And then finally, we need to monitor changes during our activities. If I tell you to go to Walmart, walk around for a couple minutes, and after 4 minutes, you start to get dizzy and nauseous, I need to know what happened. Okay. So if you're trying to go through and essentially microdose yourself with limited exposure, I want you to jot down what symptoms are going up. We want to know that, hey, when I went to Walmart, I started to get dizzy and nauseous, or I got a little disoriented after 5 minutes. And we want to know that because that can help guide our recovery. That way, the next time that you go and try it, we know that, hey, this time around, I made it 12 minutes before I started to get a headache, or I made it 7 minutes before I got disoriented, or I didn't get dizzy at all while I was there doing that activity. Okay. That way we can kind of grade our return to life while monitoring for the success rate. Okay. And then finally, reintegration back into concussions, like back into life after concussion, is a very fluid concept. You're not going to go from being completely isolated to back to normal right away. There may be times where you've got a stretch of days where you're feeling pretty good that you do more. And then you've got times where it's like, man, I really don't feel good today. So you pull back a little bit. You need to ebb and flow and kind of ride the roller coaster of concussion recovery. And that's one of the biggest challenges when we try to get somebody to reintegrate back into their normal life routine, is they will struggle with the idea of, hey, just because I could do things yesterday doesn't mean I can do things today. A lot of times when we talk about changes in relationships and loss of relationships, it tends to be because of that right there. Why could you do this yesterday, but you can't do it today? Why can you go through and do this? Why could you do it 2 weeks ago, but you can't do it now? How can you go out to dinner with family and friends, but you can't make time to have a phone conversation with me on a Sunday? Those type of things need to be communicated back and forth. It's not that your people don't like you. It's not that you don't have that relationship anymore. It 100% has to do with the tolerance that you have for the certain activity that we're doing. So to wrap things up, kind of put a bow on it, thanks for joining in. Thanks for watching. Today we talked a little bit. If you want to go back and watch the replay, we talked about concussion recovery timelines, expectations on what everybody will look like, kind of the general overview on what timelines look like. We talked about return to learn and return to work protocols, and finally some reintegration techniques back into your normal routine. My name is Matt. I am the owner of the Virtual Midwest Concussion Clinic. Every third Wednesday of the month at 12 Eastern, right here on TikTok Live, on YouTube Live, I put together monthly lunch and learns. The last 6 of them are up on the screen. They're totally free, that I put together as a way of helping raise concussion awareness and concussion education. And I keep them live up on our YouTube for you to watch and kind of go through as needed, because I understand that most people don't care about concussions until something happens. So we want to make sure that we have those available to us if you are struggling. Feel free to be a friend, tell a friend, share that with people. I love, watching things happen. I love being able to support people and talk about the world of brain injuries, world of concussions overall. So if you ever have any questions, anything that you want to know more about, feel free to follow along on all of our social media accounts at MW Concussion here on TikTok, Instagram, X, YouTube, our Midwest Concussion Clinic on Facebook and LinkedIn. The whole goal of those social media accounts is that I want to keep as much free information coming out to kind of guide you through concussion recovery, to answer questions. And I'm available to you if you're struggling, if you need help to navigate through your concussion recovery. I'm here to help do that. Again, thank you to everybody who paid attention and followed along. My name is Matt, the owner of the Virtual Midwest Concussion Clinic. Take care. Have a great rest of your day.